Good afternoon. My name is Amanda Butch. I am part of Capella University, and today I will be presenting my PICO question and my evidence based project focused on reducing recurrent urinary tract infections in the elderly population, specifically living in skilled nursing facilities. Today, we're going to start with the problem, which is that we see that there are rising rates of antibiotic resistance in uropathogenic bacteria, which actually compromise patient outcomes and prolong hospital stays. Antibiotic treatment for UTIs is often empirically started before results of things such as diagnostic cultures are available, and thus we see an overuse and misuse of antibiotics promoting the development of antibiotic resistant bacteria. According to the Centers of Disease Control, we see that drug resistant UTIs are actually increasing, especially strains such as E. coli or ESBL, which are resistant to multiple antibiotic classes. What we will talk about today specifically is the PICO question that I've developed, which is in elderly residents aged 65 and older living in skilled nursing facilities with a history of recurrent urinary tract infections, does the implementation of concurrent interventions such as urine cultures, screening, and optimizing antimicrobial use and using non-pharmacological strategies such as CHG hygiene on catheters, adequate hydration, and overall education compared to standard care using only antibiotic treatment lead to a reduction in actual recurrent UTIs and antibiotic resistance over a 6-month period. Why this matters? The elderly population is particularly vulnerable due to factors such as weakened immune systems, frequent catheter use, and higher rates of asymptomatic bacteria. Most elderly population do not display typically with things such as pelvic pain or burning upon urination. We do see symptoms such as altered mental status, typically in skilled nursing facilities, and this leads to increased hospitalizations and overall contributes to the growing problem of antimicrobial resistance. So we see that there needs to be a more thoughtful approach and a targeted approach to treating recurrent UTIs rather than solely relying on antibiotic prophylactic use. So what we see is background in terms of the literature that I used for my study. UTIs are a significant and growing health concern. They're one of the most common bacterial infections worldwide, particularly, as I said, in the elderly population, especially in long-term care facilities. The growing rates of resistant bacteria contribute to longer hospital stays, increased complications such as sepsis, and overall higher mortality rates in the vulnerable population of the elderly. Inappropriate use of antibiotics, such as prescribing antibiotics prior to the confirmation of infection, such as using cultures, promotes the risk for resistant bacterial growth overall. Addressing the issue of antibiotic resistance is absolutely necessary and pivotal to improve patient safety in the elderly population and to overall preserve the effectiveness of current antibiotics used to treat UTIs now. The recommendations that I hope and highly implore in the nursing community and interventions overall that should help stave off the use of antibiotics in general are always obtaining urine cultures prior to the start of antibiotics to limit the overuse of antibiotics, antimicrobial stewardship programs which ensure antibiotics are used only when necessary and they're tailored to specific infections, and non-pharmacological strategies such as stated earlier, CHG wipes for catheter care, improved hand hygiene, making sure all residents in the skilled nursing facility are adequately hydrated, and overall education for staff and residents as a whole to implore hygienic practices overall, such as perennial hygiene, and just keeping hand washing at the forefront of all interventions. Some diagnostics that can be used for UTIs, as we said, are urinalysis, urine cultures, just to make sure that antibiotic use is highly curated towards the specific infection that is being treated, rather than simply prophylactically prescribing antibiotics without knowing that there is an actual infection process brewing. We see that the multiple articles and journals that I used, they are highly peer-reviewed articles, and they're recent. We see that Sachi et al. 2021 is a recent article. It's an observational study that highlights inappropriate prophylactic antibiotic use in outpatient settings and how it is a disservice to antimicrobial stewardship. We see Shimimen et al. 2024, also a peer-reviewed article with that is level 1 to 3, highly appraised. Its key findings are non-pharmacological strategies and standard use of cultures prior to antibiotic treatment. And Simoni et al. 2024, also a recent article. It was actually published in Nature Reviews Urology, and it presents emerging strategies for curbing antibiotic-resistant UTIs overall, such as stated earlier, ESBL and E. coli. And it also talks about the use of CHG wipes and the steady use of diagnostics to reduce resistance. All sources are peer-reviewed and current within the time frame of 2021 to 2024. In summary, the evidence strongly supports a shift from antibiotic prescription prophylactically and more towards individualized, curated prevention and treatment plans on a case-by-case basis, using antimicrobial stewardship programs that keeps everyone on board on the same page, and how the treatment of, as stated, patient-to-patient issue reduces the occurrence of UTIs and can hopefully stave off the emergence of resistant organisms in the elderly. By implementing evidence-based interventions in skilled nursing facilities, the hope is to ensure safer, more effective care on a patient-by-patient basis, curated to patients themselves rather than patients as a whole. Thank you so much for listening to my presentation. Thank you so much. Have a great day.